What's up, Ninja Nerds? In this video, we're going to be talking about hyperkalemia. If you guys want to follow along with some awesome comprehensive notes and beautiful illustrations, go down to the link below in the description box. It'll take you to our website. Go check that out. Also, if you guys benefit from this video, it makes sense, you enjoy it, you have fun, please hit that like button, comment down in the comment section, and please subscribe. All right, let's start talking about hyperkalemia. All right, Ninja Nerds, so when we talk about hyperkalemia, first off, how do we define hyperkalemia? It's an elevated potassium level within the blood. That's all it is. Hyperkalemia is an increased level of potassium within the blood. Now, the question that you guys are going to be asking is, what causes someone to develop elevated potassium within the blood? I'm so glad you asked, Ninja Nerds. You're so intuitive. It is actually, there's a couple different causes. There's three particular overall different kind of concepts, and within that concept, there's multiple tiny little causes. But we're going to kind of group them together to help us to remember these causes very easily. So the first kind of like overall type of cause is that there is a reduced excretion of potassium. So there's a reduced excretion of potassium. Now, let's think very, very simply. What organ is responsible for excreting or secreting potassium? The kidneys has definitely got to be one of them. Absolutely. You know, whenever somebody has a condition like acute kidney injury, like a very severe acute kidney injury, so let's say that they have some type of severe acute kidney injury, or they have very severe chronic kidney disease, or maybe they have an acute kidney injury that's developed on top of their already present chronic kidney disease. In these situations where these patients are severely oliguric. What does that mean when you're oliguric? You make very, very little urine. Maybe it's like less than 0.5 cc's per kg for about at least 6 or more hours. And maybe worst case scenario, they could even be anuric, which is they don't make any urine. And these patients who are oliguric, severely oliguric, or anuric with an acute kidney injury or chronic kidney disease or an acute on chronic kidney injury, their ability to be able to excrete potassium decreases. You know, in the different portions of the nephron, for example here, if we take this tiny little diagram of our nephron, here we have the afferent arteriole, so this would be the afferent arteriole, this portion here. This would be the efferent arteriole. This right here would be the glomerulus. Here you would have your Bowman's capsule, proximal convoluted tubule, loop of Henle, distal convoluted tubule, and then the collecting duct, right? In the distal convoluted tubule, that's really where potassium is actually excreted. So potassium is primarily excreted into the kidney tubules in the distal convoluted tubule, but it depends upon a very specific type of hormone. But regardless, let's say that the hormone's being produced, but in a person who has AKI or a chronic kidney disease, these cells of the distal convoluted tubule are damaged, and their ability to respond to that hormone and then excrete potassium is diminished. That therefore leads to decreased excretion of potassium. So when they're actually supposed to be excreting potassium, that function is decreased because of damage to those cells, even if the hormone is present. Here's another thing. If a person has some type of severe kidney injury, right, whether it be an acute, whether it be a chronic kidney disease, their ability for blood to flow in, right, via the afferent arteriole and then exit out via the efferent arteriole. You know, there's this process when you run through the glomerulus, you have to filter things out across the glomerulus. That's called the glomerular filtration rate, right? And patients with an acute kidney injury and a chronic kidney disease or acute on chronic, they have a very diminished GFR. If they have a reduced GFR, that means that there's less of the potassium that's being filtered across the glomerulus. That means less potassium would end up in the kidney tubules, less potassium is being excreted. As a result, what does that mean? If you have a decreased GFR, that means you're not filtering as much of the potassium out. So what happens to the potassium then? The potassium stays within the bloodstream. And so as a result, you develop an increased potassium in the blood for two reasons. One is because you can't excrete it, so it stays in the blood. So if you kind of imagine here, here's the potassium. Imagine that these cells are distal convoluted tubular cells, pretend. These are supposed to be excreting potassium, right? But because they're damaged, that capability is impaired. These are the things that can lead to hyperkalemia. So what I want you to remember, reduced excretion due to acute kidney injury or chronic kidney disease, or acute on chronic kidney disease. All right, let's come down for a second. And the next concept is what else could cause a reduced excretion or diminished excretion of potassium? Well, go back. What did we say was the hormone that works on that distal convoluted tubule? Aldosterone. Where's aldosterone made? You know, you have an organ called the adrenal cortex. And in the adrenal cortex, you have these cells at kind of like the top part here called the zona glomerulosa. The zona glomerulosa is responsible for making a hormone called aldosterone. What does aldosterone do? Aldosterone normally wants to be able to get inside of cells where, again, it acts particularly in the distal convoluted tubule. So pretend I'm taking a piece of this tubule and I'm zooming in on it, okay? Aldosterone actually is a steroid hormone, so it can pass right through the lipid membrane. And it binds on to little intracellular cytosolic receptors and then activates particular genes. Now, when it activates these genes, it activates genes that help to make a couple different types of proteins. One of the proteins are these sodium channels. We'll have that as maroon. And then the other ones here we're going to draw in blue, we'll call these the potassium channels. Okay? So it helps to be able to synthesize these, and it also makes another channel. We can do one more protein here, called a sodium potassium ATPase, and it usually puts that like right here on the basolateral membrane. Either way, I only want you to focus on one of these proteins. So as a result of aldosterone stimulating these cells in the distal convoluted tubule, it makes all these proteins. The overall process here is that when filtrate is coming down through the distal convoluted tubule, it should contain sodium and it should contain potassium, right? Sodium is supposed to be able to move through these channels and then via the sodium potassium ATPase get pumped into the bloodstream, right? So that reabsorbs sodium. And then as a process, you use these sodium potassium ATPases to pump potassium into the cell and then excrete potassium into the filtrate to actually be urinated out. Well, in a person who has hyperkalemia, what do you think is the issue? What if they had a disorder that caused them to have a decrease in aldosterone? That means this process here is actually not going to be happening. So little sodium will actually be reabsorbed. And this process here where potassium is supposed to be pushed into the cell and then pushed out of the cell is actually going to be impaired. And so little potassium is excreted. What's the end result then? The potassium that you were supposed to push into the cell from the blood and then out into the filtrate isn't happening. So the end result is that you increase potassium levels within the blood. It's a very simple concept. Now here's another thing. Not only can it be hypoaldosteronism, you know there's drugs that affect the renin, angiotensin, aldosterone, ADH system. You know in the kidneys, you have these cool little cells called the juxtaglomerular cells. Let's just have them like right there. There's our JG cells. And the JG cells make a hormone called, or an enzyme really called renin. And what renin does is it works on a molecule called angiotensinogen and converts it into angiotensin 1. And then angiotensin 1 goes to the lungs. You know there's an enzyme in the lungs. There's an enzyme here called angiotensin converting enzyme. We call it ACE. And what ACE does is it actually stimulates the conversion of angiotensin 1 into a molecule called angiotensin 2. And then you know what angiotensin 2 does? It comes over here and stimulates aldosterone production. And then aldosterone would work on these channels to be able to regulate increased sodium reabsorption, potassium excretion. You know there's a drug that we commonly utilize on a daily basis if we're in pain, and it's called NSAIDs. NSAIDs actually have the ability to inhibit renin production. And if you decrease renin production, you decrease the conversion of angiotensinogen into angiotensin 1. You decrease the activity of angiotensin 1 forming angiotensin 2 and decrease angiotensin 2 stimulating aldosterone. That results in a decreased aldosterone production. It's the same kind of process there. What if there's another drug that I actually use to inhibit ACE? What is that drug called? ACE inhibitors. I give an ACE inhibitor. These ACE inhibitors, NSAIDs, actually inhibit ACE. That means less angiotensin 1 gets converted into less angiotensin 2, less aldosterone production. You know, there's another drug we use to block the receptors that angiotensin 2 binds to. What do we call those? Angiotensin II receptor blockers. They inhibit this process. So they'll block angiotensin II binding to the cells of the adrenal cortex and drop the aldosterone production, infecting this process. Why is this important? Because we prescribe NSAIDs for pain, we prescribe ACE inhibitors for blood pressure control, angiotensin receptor blockers for blood pressure control. You know, there's one more drug. There's another drug. So imagine here is actually that little receptor. You know, there's a receptor here. That's where the aldosterone will bind. So here's aldosterone, right? We'll put it like this. Aldosterone wants to bind onto this receptor, which wants to stimulate this genes to activate those particular channels that we already talked about above. We're not going to go that crazy there, right? There's another drug, which are called your potassium. It's kind of beautiful when you think about it. Potassium sparing diuretics, like spironolactone or eplerenone. These work by blocking aldosterone binding to those receptors. If aldosterone isn't able to bind to these receptors, it is able to stimulate these genes that cause sodium reabsorption, potassium excretion? No. So therefore sodium isn't reabsorbed, and therefore potassium isn't excreted. What's the overall end result? Hyperkalemia. So that's the overall goal that I want you guys to get out of this. So the end result is that if there's a reduced excretion, it's due to the kidneys having an issue, a disease of the kidneys, AKI, CKD, or there's something wrong with the hormonal system, aldosterone, whether it's a direct problem or it's an indirect problem through the medications that we commonly prescribe. Okay, now that we covered that, let's cover the next overall lump of causes of hyperkalemia. All right, so the next overall kind of like genre of causes is usually what's called a transcellular shift. So this kind of deserves a really quick discussion. So there's a transcellular shift of potassium, okay? So this is an interesting conversation. So potassium is in higher concentration in what part of the body? Is it in the cell, intracellular fluid, or is it outside of the cell, in the extracellular fluid? It's actually 95% of that dang potassium is located inside of our cells. They're like bags of potassium. So 95% of the potassium is inside of our cells. So in order for us to have hyperkalemia, increased potassium in the blood, the extracellular fluid, that means that the potassium is having to go, which is 95% of it is in our cells, and it has to go out of our cells into the bloodstream. That is pretty much what a lot of these are going to be talking about. So let's think about things that can actually cause the movement of potassium from inside the cell to outside the cell, into the blood. The first one is I want you to remember that our pancreas, our beautiful old pancreas, makes a hormone called insulin. And insulin works on these particular types of proteins. You know what this protein is called? This son of a gun is called the sodium potassium ATPase. And what it loves to do is pump potassium into the cell. How many potassium? It pumps 2 potassium into the cell, and it pumps 3 sodium out of the cell. That's kind of the function of the sodium potassium ATPase. And it obviously utilizes ATP. Insulin loves to stimulate the sodium potassium ATPase, right? So that's what I want you to remember. Insulin normally wants to stimulate the sodium potassium ATPases. So what do you think would be an issue? This normally, if it's stimulated, would push potassium into the cell. So what would we need in order for the potassium not to be pushed into the cell? We would need a decrease in insulin or no insulin. So in conditions where patients have a decrease in insulin or the receptors of insulin is very sensitive or resistant, what is those conditions? Diabetes. So in patients who have diabetes mellitus, whether it be type 1 or type 2. You'll see it a little bit more in type 1 because there's very, very little insulin. But in type 2, if the cells are very, very resistant to insulin, it's just as the same. Their ability to activate these pumps are going to be inhibited. So if there is a decrease in insulin, you inhibit these pumps. You don't pump the potassium where it wants to go into the cell. Instead, you're actually going to keep it outside of the cell in the blood or in the extracellular fluid. Okay, there's other things. Drugs. I know it's always coming down, but these are important things because we prescribe these medications very often. You know, there's a drug that we actually give to patients. It's called a beta blocker. And there are different types of beta blockers, right? There's beta blockers that are very specific. They only work on like beta 1 receptors. And then there's ones that are really kind of like, they're kind of like happy-go-lucky. They'll bind to a beta 1, they'll bind to a beta 2. They're like, hey, baby, I'll do whatever you want. So we got different types of beta blockers. They're non-selective beta blockers. And that's important because on certain cells that have what's called beta 2 receptors, these beta blockers may be able to bind on to these beta 2 receptors, and these beta 2 receptors normally they work to be able to stimulate these sodium potassium ATPases. So if I give a beta blocker, that's going to inhibit the actual beta 2 receptor and therefore lead to an inhibition of the sodium potassium ATPase. I don't push potassium into the cell. Very simple, right? So beta blockers within the genre of the beta 2 receptor particularly. And then the next thing is we give another drug that we give actually in heart failure or in patients with AFib. And one of the benefits of this drug is that it causes like more contractility, and it's called digoxin. Digoxin literally directly affects this channel. And so what digoxin actually does is digoxin actually inhibits, we'll put here some digoxin here. Digoxin actually directly inhibits this sodium potassium ATPase. And so it doesn't allow potassium to get pushed into the cell, stays outside the cell. There's one more cause. You know, in conditions where we have lots and lots of protons, whether this proton be due to an increase in CO2, because you know CO2, when it combines with water, it makes carbonic acid, which breaks down into protons and bicarb. Well, that's one way. If you have a lot of CO2, you can make protons. What's that called? Respiratory acidosis, right? If it's primarily a lung disorder. Or it could be due to things like organic acids, right? So lactate, or lactic acid, sulfuric acid, phosphoric acid, different things like that. So different organic acids, keto acids, all of those things. So whenever there's an increase in protons, there's an acidic environment. Whenever there's lots of acidic environment in the extracellular fluid, what we want to do naturally, there's like a channel here. Imagine there's like a channel here on the cell. So here's this channel. Normally what we want to do is if the protons are really, really increasing, what does it do to pH? It reduces the pH, right? So what we try to do is, let's say, we kind of hide it in a way. We say, let's put the protons somewhere else besides the blood, and then we can kind of pretend like the pH is kind of normal. So we'll shift the protons somewhere else. Well, if I'm going to shift a proton into the cell, this is a positive charge. I need something else that's positive charge so I can maintain an electroneutrality in this cell that I can push out. What can I push out? Potassium. And so what I'll do is I'll push potassium out in exchange for that proton. The more protons there are, the more you're going to push in, the more potassium ions you're going to push out. So in severe acidosis, whether it be respiratory, whether it be metabolic acidosis, this can really cause a lot of potassium to get pushed out of the cell because you're trying to push protons into the cell to mediate that acidic environment. Okay, beautiful. That covers that part. What else is another way that we can actually shift potassium? Not only does diabetes directly affect it through the insulin process, but whenever there's high amounts of glucose kind of in the blood, what do we call that? Whenever the blood is really, really kind of rich in solutes and very little fluid. What do we call that? It's called hyperosmolar, right? So we call it hyperosmolar. So in a hyperosmolar state, right, what's a disease which causes a hyperosmolar state related to glucose? There's a condition called HHS, hyperglycemic hyperosmolar state. And this can happen to patients with diabetes where they have very, very high glucose levels. In those situations where there's really, really high glucose levels, it kind of does what to the water which is inside of our cells? The water looks at it and it's like, lots of glucose out there. I'm going to go out there. And so the water will then say, all right, I'm going to leave out of this cell to come to where all of this actual sugar molecules are because it's going to draw it like an osmotic gradient. Therefore, the hyperosmolar term. That pulls water out of our cells and into the blood. When you pull water out of the cell, water helps to kind of be able to maintain somewhat of a concentration gradient. So for example, when you take potassium, the more water there is in that cell, it kind of affects the potassium gradient. But when water leaves, there's less water in the cell, and so that kind of affects the potassium gradient. And now, whenever water leaves the cell, so let's say that there's actually, as a result of water leaving, there's decreased water in the cell. This results in kind of a higher potassium concentration inside the cell in comparison to the potassium concentration outside the cell. And what that does is that high concentration gradient yanks the potassium out of the cells and into the blood. And then as a result, the potassium levels in the blood will increase because you're pulling potassium out of the cells because of this hyperosmolar state or hyperosmotic gradient. What's another condition that not only can cause this? What if you're super, super dehydrated? So sometimes in conditions where there is significant dehydration, you can cause the actual body to become a little bit more hyperosmolar because there's less fluid, right? Less fluid within the extracellular space. So in the same way, you're going to cause lots of solutes, lots of salt, right, that can actually build up within the bloodstream because you're actually pulling off fluid in the sense of dehydration. Or excessive diuretics. So excess diuresis. You know, in patients who get lots of like loop diuretics of some form, it may pull off a lot of fluid, a lot of dilute fluid, water, and then lower the actual amount of water in the vasculature. And because of that, it makes it a little bit more hyperosmolar in the sense of maybe there's more sugar molecules, there's more salt molecules there. And so these are things that you want to think about. And that can create a pull of water into the actual tissue spaces and into the blood. But as a result, it changes the concentration gradient of potassium, which pulls more potassium out as well. Okay? All right, so we finished up talking about these causes of transcellular shift. Let's come down and talk about a couple more causes of a transcellular shift. So you have patients who, maybe they have some type of seizure, right? Or maybe they have a severe crush injury. And this causes a lot of damage to their skeletal muscles. And their skeletal muscles is a result of maybe like extreme exertion, seizure activity, crush injuries. It causes the skeletal muscle damage. And the skeletal muscles are cells, right? They're containing cells. And what are cells made up of? Cells are just bags of potassium. And so these cells start popping open, releasing things like potassium, releasing things like creatinine kinase, releasing things like myoglobin, right? And this can be a process. What's one of those things? Potassium. So that could be one way that could lead to increased potassium levels in the blood. And a condition called tumor lysis syndrome. Tumor lysis syndrome. Tumor cells, particularly like, whenever you have like leukemia, lymphoma, and they get chemotherapy, and these cells start getting damaged from the chemotherapy, they start popping open, releasing tons and tons of molecules inside of their actual cells. One of them is potassium, or they start releasing phosphate, or they start releasing other types of molecules like uric acid, right? So tons of different things start kind of increasing inside of the actual bloodstream. And this could be a sign of tumor lysis syndrome. The other thing that you want to be thinking about is if someone has some type of damage to their red blood cells. What is this called whenever you lyse open or pop open the red blood cells? It's called hemolysis. And whenever this happens, for whatever the hemolytic cause is, you pop open these cells and you start releasing, what's one of the components? Potassium. You also start releasing hemoglobin. And then there's also going to be kind of an increase in bilirubin. So there's a lot of different things that can happen as a result of this, right? So this would be particular things that you have to be able to think about. All right, so I wanted to take a quick second to fix up these Roman numerals so that we have the third and then the fourth kind of causes, kind of categories of causes of hyperkalemia. So this next one, it's not super common. It'd be pretty hard to do, but it can happen, especially if you're taking medication for like hypokalemia, and you take too much of it, or you decide, I don't know, to go ham and eat tons of bananas, or you're getting a lot of potassium replacement therapy and you're getting just more than you actually should have, and you have chronic kidney disease or acute kidney injury, whatever it may be. It's the last cause that I want you guys to kind of, the last kind of big one to think about here is some type of increased potassium intake. Whether this be in certain foods, whether this be in the medications that you're taking potassium, you're getting potassium replacement therapy, if there is an increase in the amount of potassium that you're taking in, whether it be via the gut or whether you're getting potassium IV because you're in the hospital for some reason, and you're getting just a little bit too much potassium, this maybe leads to an increased absorption of potassium across the gut or an increased delivery of potassium into the actual venous circulation. And either way, that may lead to hyperkalemia. It's not super common, but it is one to think about. It's one of the easiest ones probably to remember, right? As you give potassium, it's going to cause hyperkalemia. Now, the last one, and believe it or not, probably one that you'll see more often than not, and you definitely want to remember, is what's called pseudo hyperkalemia, where you actually think that it's hyperkalemia. The potassium levels will show up elevated, greater than 5, because generally like it's 3.5 to 5 is like the normal range for potassium. So what will happen is you can order labs, right? And you know when patients get venipunctures and they use like the tourniquet, or maybe they're using like some type of like smaller IV, whatever it is, when they're drawing blood, and especially with very intense tourniquet use or it's staying on for a long period of time, some of the red blood cells, when it gets taken up during the blood draw, they lyse. What does red blood cells contain? Potassium. So if they lyse and pop open, what can they release into that actual blood sample when you're taking it? Potassium. And so whenever they run that test, that BMP, to give you your potassium value, it can be falsely elevated because a lot of the cells actually rupture during the venipuncture. So during venipuncture, sometimes you may have these elevated potassium levels. What you have to do is, usually the tech will actually look at the actual blood sample under the actual microscope and look to see, oh, there was a lot of hemolysis. So, you know, the specimen's not actually super correct because it was hemolyzed. And so that's a big thing to think about. Another thing that can actually kind of present like pseudohyperkalemia that's not due to a hemolyzed venipuncture is sometimes if people have very high platelets. What is that called? So they have what's called thrombocytosis. Sometimes in high levels of platelets actually contain granules that have potassium. So you have tons and tons and tons of platelets and they pop open and they release their potassium. That also can cause hyperkalemia. So in these two situations, just remember that pseudohyperkalemia is a very common cause. One of the most common is the venipuncture process where it gets a hemolyzed sample. Another one could be a thrombocytosis. All right, that covers all the causes of hyperkalemia. Let's now talk about the pathophys. All right, engineers, so let's talk about how hyperkalemia leads to the particular clinical manifestations and certain types of electrocardiographic features that we may see in a patient who presents with hyperkalemia. So really quickly to kind of go through the pathophys so we have a basic understanding of it. You have to have a basic understanding of the membrane physiology. If you guys want a little bit more understanding on that, go watch our video on resting membrane potential, graded potential, action potentials. It'll really help you to understand this. We're going to kind of briefly go through it though. So quickly understanding is that you have a cell that's has what's called a resting membrane potential. So really quickly, if I were to have something like this here, this kind of graphical representation, you have a cell that has what's called a resting membrane potential. What's that normal resting membrane potential in cells? Usually it's like -70 millivolts, right? That's about what it is. Now, the resting membrane potential is kind of carried out by a couple different types of channels. The big ones that I want you guys to remember is you have what's called the sodium-potassium ATPases, right? That normally they function to pump two potassium into the cell, and they pump 3 sodium into the cell. That's one of the things that contributes to the resting membrane potential. But the more important thing that contributes to the resting membrane potential of excitable cells, what are excitable cells? Cells that are cardiac muscle, smooth muscle, skeletal muscle, and neurons. Those are kind of your excitable cells. And those types of cells, they have these things called potassium leakage channels. And what they normally do is they allow for potassium to move out of the cell. Because you know, normally potassium is in high concentration inside of our cells and in low concentration out of the cells. And so potassium will leave, and that if you have a positive ion leaving, that makes the inside of the cell negative. So that's why the resting membrane potential should be relatively negative. Now, what happens is this is what contributes primarily to what's called your resting membrane potential, right? And you know, whenever a cell becomes like excited, whenever you have an excitable cell, you have to have some kind of stimulus, right? Like there's a stimulus that you have to be able to reach something called a threshold potential. So normally cells at rest, and it has to get to a point of what's called a threshold potential to be able to have like an action potential. And so that's where you need something called graded potential, something that stimulates the cell, brings it up to that threshold. And then it can have what's called an action potential. So it would look kind of something like this, right? You'd get up to threshold potential through that graded, get up here, come down, you'd overshoot a little bit, and then it would go back into that resting state, ready to be stimulated again. And what happens in this kind of effect here is that in order for you to have this point here, which is above, called the action potential, you have to have these things called your voltage-gated sodium channels open. And you know, what happens is in these kind of phases is that whenever you hit threshold potential, let's say that this is the sodium channel at the threshold potential, whenever you hit that threshold potential, normally before you hit it, this is what it looks like before. So let's actually say right before, let's actually be more specific, right before threshold potential. This is what it should look like. This is called your activation gate, and this is called your inactivation gate. Normally this one's closed and this one's open. But what happens is once you hit threshold potential, and you get to the, the action potential, like the peak part of the action potential, it should look like this, where the activation gate should be nice and open, and the inactivation gate should be slowly starting to close. And what happens in this phase is this where sodium is just loading into the cell, right? It's making the cell super positive. And then after that, you kind of go back down to this original state that you had here. So this right here is at the resting membrane potential state, right? Where your activation gate is closed and your inactivation gate is open, but sodium can't get into the cell here. It's blocked. So this is kind of the normal cycle of your sodium channels. Well, guess what happens? Potassium is in higher concentrations now outside of the cell. So now your potassium level that you have inside of the cell, so you should normally have high potassium inside the cell and low potassium outside the cell. But now in a patient who has hyperkalemia, the potassium outside the cell is a little bit higher than it should be. And that affects the concentration gradient. And so as a result, less potassium leaves. So if less potassium leaves the cell, that makes, instead of the resting membrane potential being like slightly more negative, -70, it actually can make the resting membrane potential less negative. And if I make the resting membrane potential less negative, let's pretend for a second that now the new resting membrane potential is actually like right here. So let's actually call this the resting membrane potential prime. That's the new one. Well, guess what? If because of that, hyperkalemia does that, let's say that you get a stimulation that you happened here before, right? So you have hyperkalemia, you get like this action potential that occurs. But then what happens is, normally your actual cell will go through this phase of you hit threshold, you cause an action potential, and then it should go back to a resting membrane potential. And the only way that it rests, it's in this state, is if you hit -70 millivolts. That's the only way. Well, if my new resting membrane potential is not -70, it's actually like more positive now, will I ever be able to get these sodium channels that are stuck in inactivation open again? No. And so because of that, the sodium channels in hyperkalemia, the voltage-gated sodium channels become locked in the inactivation state. Inactivation state. And that means you can't stimulate this cell. If I can't stimulate this cell because it's stuck in this inactivation state, that means that the cells become less excitable and their activity of cardiac muscle, smooth muscle, and skeletal muscle and neurons all declines. What can that present as? I'm so glad you asked. If you affect skeletal muscle, let's just say skeletal muscle of like the limbs, what would happen if you have less excitable muscle cells, skeletal muscle cells? They're not contracting. If they're not contracting, what will that present as? Weakness. If your neurons are less excitable, if they're less excitable because they're locked in this inactivation state and they can't be brought to their true resting membrane potential, what happens to the actual action potentials of neurons? There's decreased action potentials of neurons. And this may lead to, again, neuromuscular weakness, right? Because if neurons actually serve muscles, so that can also kind of lead to weakness. But also, when you check reflexes, those are supposed to be a response of electrical activity. If there's a decreased responsiveness of the neurons, decreased excitability, you tap a reflex, what do you think is going to happen? They're going to have decreased reflexes. So this can lead to what's called decreased deep tendon reflexes. What about the smooth muscle of the GIT? It's supposed to be able to contract and move stuff through the actual GIT and poop it out. What's going to happen if you can't do that? You can develop constipation. Sometimes, maybe even an ileus. And you know what else? If things aren't moving through the actual GI tract, they start backing up. And you aren't able to get it out. It's going to come through one hole. It might start leading to nausea and vomiting. Okay? If it's affecting the cardiac muscle, so now the cardiac muscle is less excitable. It's normally supposed to be able to be excited, be stimulated, and want to contract. And if that doesn't happen, what will that result in? It results in a decreased contractility of the heart. If there's decreased contractility of the heart, what does that do to the cardiac output? That decreases cardiac output. What does that do to the blood pressure? It may reduce the blood pressure. So there may be a decreased contractility of the heart, but also it can lead to a lot of nasty kind of EKG changes. We'll put here, changes there, a lot of arrhythmias. Particularly, it would lead to a decreased type of heart rate, right? Because if you have less excitability, it's not going to want to be able to be stimulated as much, and so it'll be a slower conduction. So that may present as bradycardias, maybe heart blocks, maybe sinus bradycardia, and we'll talk about some other things. Prolongation of the PR interval. What about the muscles, the skeletal muscles that are also important for breathing, the diaphragm, the intercostal muscles? They're all jacked up now. What about those poor guys? In this situation, this can lead to difficulty breathing, like respiratory distress. And one of the other key things to think about is in someone who has hyperkalemia, what may be the most common cause? Acute kidney injury, chronic kidney disease, and what happens in those kinds of patients. And those patients who have acute kidney injury and chronic kidney disease, which is usually the most common cause of someone having hyperkalemia, they may have a decrease in urine output, or worst case scenario, no urine output. What's it called when you have decreased urine output? Oliguria. What's it called when you have no urine output? Anuria. So these may be some of the clinical features that we see in a patient who has hyperkalemia. All right, let's do a mnemonic to help you guys to remember it. All right, so we talked a lot about a lot of the clinical features and decreased excitability of cells, but let's try to have a nice little way of remembering hyperkalemia for your exams. And you know how you can remember it? There's been a murder in Savannah. If you know, you know. But the whole mnemonic here for murder is that M is for muscle weakness, so decreased skeletal muscle excitability. Low urine output, oliguria, anuria, right? Or no urine output for anuria. This would be a situation where someone has acute kidney injury, chronic kidney disease. Respiratory distress due to the diaphragm, intercostal muscles. Decreased cardiac contractility, decreased cardiac activity. EKG changes due to the effect on the cardiac muscle, and decreased reflexes due to the decreased activity of the neurons. And if you wanted to add in another one in there, you could add in that GI activity as well. But that's going to be how you guys remember the basic clinical features or signs of hyperkalemia. Now let's talk about the diagnosis. All right, so how do we go about diagnosing hyperkalemia? Well, it's actually a relatively simple diagnosis, right? In order for you to have hyperkalemia, what does the potassium have to be greater than? It has to be greater than 5, right? So really, you have to start off kind of saying, okay, we have to have a potassium level that is greater than 5. And that's kind of the average range is about 3.5 to a 5. So if I have greater than 5, I know that it's actually hyperkalemia. But to be really, really careful, one of the first things you have to do is go back to remember your causes. We spent so much time on causes because it's actually important for the diagnosis, right? You can easily diagnose hyperkalemia, but finding the cause of hyperkalemia is important. So the first thing is you have to rule out pseudo hyperkalemia. And again, what did we say was the two particular causes behind that? Was a hemolyzed sample. So usually the lab will actually write down if you have a hemolyzed sample. Or what could you do? If it was a hemolyzed sample, send another one, send a repeat one. Maybe grab it from an arterial line or something and see what happens if you actually get it from a different line, or you try another stick. Or try it from an arterial line, see what happens. If it comes back and it's actually still elevated potassium, it might actually be real. But ask the lab, is there any signs of hemolysis, or draw it from another line or an arterial line, okay? The other thing is make sure that they don't have any elevated platelets. How can I check to see if they have any significant thrombocytosis? I can get a CBC. A CBC will tell me if I have any thrombocytosis, if there's a really, really large number of them. Okay, that's the easy way. Right? The next thing is, let's say, okay, we definitely have a diagnosis of hyperkalemia. What are these other particular causes that may be responsible? So now we know that there is a true diagnosis of hyperkalemia, which means that it's greater than 5 milliequivalents per liter. Now, how do I actually figure out what is the underlying cause of that? We'll go back and think about all of them. What were one of them? AKI, CKD. Look at their history. Do they have a history of CKD? What was their GFR? If they have a history of CKD and they don't have an acute kidney injury, it's their baseline. You can check their GFR. It's not good in acute kidney injuries, but it's good in chronic kidney disease. So if they have a low GFR, that may be a good idea, right? What else? Check their BUN if it's elevated. Check to see if their creatinine's elevated. But make sure that, again, is it their baseline? Is it beyond their baseline? Because if it's greater than 1.5 times their baseline, it's greater than 0.3 within the past 48 hours, it may be an acute kidney injury. So looking at that, looking at their urine output, have they had a decreased urine output or no urine output? These may be ways that you can kind of lead to this being the cause of their hyperkalemia. What was the other one? Hypoaldosteronism, right? How do I check for hypoaldosteronism? You check the dang aldosterone level. So in a patient who has hypoaldosteronism, check to see if they have a low aldosterone level. Usually if they have a low aldosterone level, they'll also have a high renin level. So that's one of the ways to determine if it's actually coming from the adrenal cortex and it's not something else. What was the other things that kind of affected aldosterone indirectly? And you can just go ahead and either, hey, do you take this medication? Or you look through their medication list and see if they take it. So what were some of those drugs? Do they take any NSAIDs? Discontinue them. See what happens. Do they take an ACE inhibitor? Do you see what happens if you discontinue? Do they take an ARB? Do they take a potassium-sparing diuretic, like spironolactone? If that's the case, look through their actual medical history or their medication list. Maybe discontinue that and see what happens to the potassium level when you draw it another day. What else? The other things that you have to be thinking about is, what if it was a hyperosmolar cause and they have diabetes? How do I determine that? Oh, I don't know. Maybe I'll just check a blood glucose, right? So what I could do is I could actually check a BMP. Oh, real quickly, what would I get a lot of this stuff from? What could I get a GFR, a BUN, and a creatinine from? I could get that from a BMP, correct? Yeah, so I can get that from a BMP. But nonetheless, let's say that we just check what's called a point of care glucose, or we just check what their glucose is off the BMP as well, because a BMP gives you their glucose as well. If they have a super high glucose, or their BMP is really having a high glucose, maybe they have a hyperosmolar state. Also, check to see if they're dehydrated. Look at their volume status. Have they been taking tons of diuretics recently? That might be another sign. You know what else you can do? What was the other cause? Acidosis, right? How can I determine if someone has acidosis? If I really want to be accurate, I can get an ABG. So if I got an ABG of a patient and I look to see, oh, wow, their pH is really low. And then from there I can determine, oh, it was because they had a high CO2. So they have respiratory acidosis. Oh, it's actually because they have a low bicarb. Oh, so it's a metabolic acidosis. That can kind of give me an idea of what was the cause of the acidosis, but the acidosis may be the very thing that's driving their hyperkalemia. And if I fix the acidosis, I may fix their hyperkalemia. What about other drugs that we talked about that cause transcellular shifting? What about beta blockers, right? So beta blockers. Do they have a history of any kind of heart failure or anything that requires beta blockers and they've taken it before? Have they gotten any digoxin lately? And again, maybe trying a discontinuation and seeing what happens might be the way to go about this. What if it's not just these things, but we actually know that they had another condition where they were popping cells open like left and right? What if they were popping open some muscle cells and they had something called rhabdo? Well, maybe they have pain in their legs, right? Maybe they have pain in their arms. They have a lot of like sore muscles. But what's something else I can check in the blood that we kind of mentioned over there? They may have a lot of CK. They may also have what's called myoglobin in their urine, myoglobinuria, which may make the urine really like darkish kind of colored, right? So that may be a sign. And what else? What if there's what's called tumor lysis syndrome? We're going to abbreviate that TLS, tumor lysis syndrome. Well, not only were you popping open cells that had lots of potassium, but you're also going to be popping open cells that have lots of phosphate. You have lots of uric acid. And there can even be other different things that are also being popped out of these cells. So whenever they have high potassium, high phosphate, high uric acid, these may be particular signs. What else? What if you have another cell, red blood cells that are actually lysing? So you have signs of hemolysis. What could I check to look to see if I have a hemolysis that's leading to anemia? I can check a CBC. But I can also check other levels that would make me think of hemolysis. Whenever these cells pop open, it actually causes the release of LDH. It can cause an increase in your bilirubin. What kind of bilirubin though? Let's be very specific. Is it unconjugated or conjugated? It's unconjugated. So here we call that indirect bilirubin or unconjugated bilirubin. And then what protein made by the liver sops up a lot of that hemoglobin? Haptoglobin. So there is a decrease in the free haptoglobin levels. So these could be ways that you could say, oh, it's a hemolysis as the cause. So these are the ways that we could go about determining if it's true hyperkalemia. Once we've determined it's true hyperkalemia, figure out the cause. Once you figure out what it is, you treat that, you fix it. Now, the last thing is sometimes a patient may not come in with any of these clinical manifestations. And all you may see is you get a 12-lead EKG. And you get a 12-lead EKG and you see some particular really weird abnormal EKG changes. What are some things that I really want you guys to take away from this and not to forget? Okay, the first one that I want you guys to remember here is that this leads to, again, decreased cardiac excitability and contractility. One of the things that happens is it causes repolarization abnormalities, right? Because again, whenever you have the action potential, it has to go down all the way to hit resting phase. But do you actually truly ever hit the resting phase, the true resting phase? No, because the hyperkalemia created a new resting memory potential. And so it affects the repolarization of the ventricles. What is this wave here that represents ventricular repolarization, the T wave? It produces what's called peaked T waves. So that's one sign here, okay? Then it may get a little bit, now this is not always the case in the exams, it says this, but it's not always like concentration of potassium in the blood dependent. You can have any of these EKG changes at different levels of potassium. In the textbook definition, it says that these kind of EKG changes occur as the potassium levels increase, but that's not always the case, okay? So just remember that in true clinical experience. Now, what else can happen? Not only can you have peak T waves, but if it gets a little bit worse, what the heck? Look at this QRS wave. That's a big mama. That's wide. That's a wide QRS. So you may start seeing signs of a wide QRS and maybe still a little bit of a peak T wave. Okay, oh my gosh. Look at that PR interval there. That PR interval is gargantuous. That's a long PR interval. So if I have a prolonged PR interval, that may lead to some bradycardia. Okay, so I'm starting to see some signs of some bradycardia. There can be like a heart block kind of sign here. Oh my gosh, the P wave's gone. So I start seeing flattening of the P wave. So not only is there a prolonged PR interval, but where the heck is my P wave? So I got flat or absent, and sometimes absent P waves. What is it called? Because this is sometimes one of the findings that I see a lot in the ICU, is that, you know what this is called when you don't have a P wave and there's no actual sinus rhythm there? What is it called whenever the AV node is now the one that's taking over? It's a junctional rhythm. Sometimes one of the most common signs of a patient in hyperkalemia is a junctional rhythm, believe it or not. So think about that. Oh my gosh, what is this? This is called a sine wave. So sometimes hyperkalemia leads to this really weird looking type of sine wave or sinusoidal type of pattern. And when you see this, it's usually a precursor for some type of ominous thing, which is usually when they start going into something like VFib, or worst case scenario, they go into cardiac arrest and they have asystole. Okay? So these are the EKG changes that I want you to remember. So quick reminder. Peak T waves, to wide QRS, to prolonged PR, to flat P wave, to a sine wave, to cardiac arrest, whether it be VFib or asystole. That covers the diagnostics. Let's talk about treatment. All right, so let's talk about the treatment of hyperkalemia. Now, it's actually not that bad. It's really straightforward. Okay, so the first thing that you want to do in a patient with hyperkalemia, generally, if you start seeing some signs of some EKG changes, so any signs that we talked about before, right? Peak T waves, you start seeing some YQRS, some prolonged PR intervals, you start seeing signs of some flattening of the P waves, a sine wave pattern, VFib, cardiac arrest, anything like that, signs of cardiac toxicity due to hyperkalemia, you have to stabilize those cardiac membranes. So not only is it EKG changes, but if the potassium level is getting really, really high, it's getting really, really high, you got to start considering potentially giving them something to stabilize their cardiac membranes. So stabilizing their cardiac membranes. Now, for a long time, I was like, what does that mean to stabilize cardiac membranes? And you just kind of assume it's like, oh, it just stabilizes it. The real actual mechanism isn't completely understood. It's actually kind of difficult to elucidate. But what we've been able to, for the most part, assume is that when you give somebody what's called calcium gluconate, so you can give them what's called calcium gluconate, and sometimes if that isn't the best situation, you may try something called calcium chloride. But either way, you want the calcium part of that. When you give them these substances, what it does is, remember, go back to that graphic appearance that we had before, okay? In the graphic appearance before, you had something here called your resting membrane potential, and then you had this thing here, which was called your threshold potential. And due to hyperkalemia, what happened? Hyperkalemia created this new resting membrane potential, or resting membrane potential prime, right? So this was the old one. And then what happened is when you had action potentials, it should normally look something like this, right? It should go here, trigger this action potential, come back down, have a little shoot there. Now let's say that we have this person who has hyperkalemia now. They'll actually go here, same thing, hit that threshold potential, come up, but now guess what? Their new resting membrane potential is right there. Guess what I'm gonna do? I'm gonna give them calcium gluconate and calcium chloride. And I'm gonna make the inside of the cell a little bit more positive to the point where I bring my threshold potential, I bring it up. I increase my threshold potential. Now I have a new threshold potential, which is above the new resting membrane potential. And so because of that, these cells may actually go into this rested state and actually have the ability to somewhat be excitable. And so that is what kind of happens in these patients who start having signs of cardiac toxicity. So the first thing that you want to do, if any signs of EKG changes or as the potassium starts kind of getting greater than 6, is you might want to start stabilizing those cardiac membranes. Calcium gluconate, calcium chloride. The second thing that we want to do is we want to control a lot of that shifting between cells. So then we have to control the shift of potassium. All right, so in other words, we're not going to be able to actually excrete potassium. This is stabilizing the cardiac membranes. The next thing is, can we push potassium like back into cells by some way and get it out of the blood? Can we do that somehow? And guess what? We can. What did I tell you was one of the things that actually stimulates sodium-potassium ATPases? Insulin. So you know what I can actually do? I can give a patient a little hefty dose of insulin. And if I give them a hefty dose of insulin, like regular insulin, that's going to stimulate these sodium-potassium pumps. If I stimulate the sodium-potassium ATPases, what will that do? It'll push 2 potassium into the cell and push 3 sodium out of the cell. But effectively, I got potassium that was high in the blood into the cell. I just transferred it, I shifted it. Sometimes if you give hefty doses of insulin, it may cause hypoglycemia. So what can we do from preventing that hypoglycemia? We can give something called dextrose, and usually in the form of like D50. Okay, to be able to give them some type of sugar to prevent that insulin dropping their sugar levels. If they're close to the verge of having normoglycemia or euglycemia, you don't want to give them a bunch of insulin and drop their glucose down to like 0. So insulin and D50 will shift the potassium into the cells by stimulating the sodium-potassium ATPases. Guess what else stimulates the sodium-potassium ATPases? What I said, the beta-2 receptors, right? Beta-2 receptors, and whenever they respond to epinephrine, norepinephrine, or some type of agonist like that, it stimulates the sodium-potassium pumps. What if I give something that's a beta-2 stimular or a beta-2 agonist? Guess what we can give? Beta-2 agonist, we can give a drug called albuterol. Pretty hefty doses of albuterol, because albuterol is a beta-2 agonist. And so what it's going to do is it's going to bind onto these beta-2 receptors and then increase or stimulate the activity via the cyclic AMP kind of process, stimulate these sodium-potassium ATPases. And what's that going to do? That's going to shift the potassium into the cell, right? Particularly, you're going to put 2 potassium ions into the cell, and then you're going to get rid of 3 sodium ions. But I shifted the potassium in. So that's one way. Albuterol, sometimes we call this a SABA, short-acting bronchodilator, right? Which is a beta-2 agonist. What else could I do? Another thing that we can do is we can control the acidotic environment. So we said that before, whenever there was lots of protons, right? Whenever there was lots of protons, this was basically causing that problem of pushing potassium where? Out of the cells. What if I give something to counteract those protons? So I give something that can bind with the protons And if I combine them together, I'll get something called carbonic acid, which is less acidic. This is way less acidic. What's that? Bicarb. Simple. So I can administer bicarbonate. And if I give them bicarbonate, what will this effectively try to do? This will effectively try to reduce the amount of protons. It's going to reduce the amount of protons that's being pumped into the cell and reduce the amount of potassium ions that's being pushed out of the cell. So it's effectively leading to this shift change. We're having less of the potassium leaving out of the cell. Usually we give bicarb if it's getting to the point where the patient has severe uremia or their pH is very, very, very low. Sometimes if it's approaching like less than 7.2. It's not always given for all patients, okay? But we stabilize their cardiac membranes with the calcium gluconate. We shift the potassium back into cells, or at least prevent the potassium from exiting via insulin, give D50 to prevent overcorrection causing hypoglycemia, hefty dose of albuterol, and bicarb in the situations of uremic acidosis or very, very low pH to where it's getting less than 7.2. All right, so we've already controlled stabilizing the cardiac membranes in hyperkalemia. We shifted some of the potassium back into the cells. What about trying to just eliminate potassium through the pee-pee or the poo-poo? That's the way that we can try to do it. And so what we can try to do is eliminate or excrete potassium if the kidneys and the bowels have the ability to do that. Now, what can we give that can actually get rid of potassium? Diuretics, right? So diuretics are going to be kind of your go-to. So when I talk about diuretics, the best one to consider is something called furosemide. Furosemide, also known as Lasix, works particularly how? You can use thiazide. You can actually add them as an adjunct. You can do like a plus or minus hydrochlorothiazide or some type of thiazide-like diuretic. You can consider those. But generally, furosemide is going to be the best situation here. And the reason why is this works in the loop of Henle. And a good chunk of potassium is actually supposed to be reabsorbed in the loop of Henle. But when you give furosemide, it inhibits this channel. You're probably like, oh my gosh, this is that beast one, isn't it? Yeah. It inhibits what's called the sodium potassium 2-chloride co-transporter. Okay? Now, if it inhibits this channel is responsible for bringing sodium, reabsorbing sodium. It's actually helpful for reabsorbing chloride, and it's helpful for reabsorbing potassium. But if you inhibit this channel, are you able to reabsorb potassium? Are you able to reabsorb sodium and chloride? No. And so because of that, all of this stuff stays within the kidney tubules. And because it can't be resorbed, at this point here, this is dependent upon aldosterone. And if aldosterone isn't going to be able to control enough of that, guess what happens? That goes right into the PP. And you get tons of potassium that should be excreted. This is called kaliuresis, right? And you may have to give sometimes some pretty hefty doses in a patient who has a pretty significant kidney injury. So this is what we would try, something like furosemide. Now, the other option is, let's say that they can't be diuresed for whatever reason. Maybe they have chronic kidney disease, or maybe they aren't able to make any urine, they're anuric. And so putting them on that actually may not work, or maybe they're just a little bit dry, they're actually a little bit dry, and you don't want to diurese them and make them actually even more dry. And you actually have to give them a little bit of fluids instead of Lasix. Then maybe you might go to another option here, which is called kyaxylate. So another drug here, it's kind of a sodium polystyrene. So it's actually sodium polystyrene. And it's actually called kyaxylate. It's kind of like the brand name of it. And what this does is, kyaxylate or sodium polystyrene, is it's responsible for actually kind of, so imagine here you have that kyaxylate molecule. One of the things that it does is it actually can release sodium ions out. And the sodium ions actually get cross the enterocytes. And when it crosses the enterocytes, a positive ion is going into the cell, so something has to be able to come out of the cell. That's also positive. And guess what actually gets kind of pushed out here? Potassium. You know what else the sodium polystyrene does? It actually kind of binds up any potassium that may be present inside of the actual GI lumen. So it kind of acts like a potassium binder. So it releases sodium ions that actually cause sodium to get exchanged and processed for potassium, and it also binds onto the potassium and tries to bring that potassium out into the poo-poo. The only downside of this one is that there has been actual risk of intestinal necrosis due to it maybe causing some compaction in certain patients, okay? Last but not least here for effective treatments is if a patient is completely refractory to all of the actual measures that we've employed, they're completely anuric, we don't want to give them any Kyaxley, we don't think it's actually going to make much of a difference, we may have to use something called dialysis. So at this point in time, when it gets to this level, we may need to do what's called dialysis. And depending upon the patient's hemodynamic stability, they may need something like continuous renal replacement therapy, or if they're pretty hemodynamically robust, intermittent hemodialysis of some type. Okay? And that's going to be responsible for taking you basically have like these catheters in the actual venous circulation. You have an arterial side and a venous side, basically. Here's the arterial side, here's the venous side. It's just the circuits, but it's all coming from a vein. Any of the potassium that's all kind of accumulated here in the blood gets sucked up through this kind of catheter, taken through this kind of colander here, and the potassium gets kind of pushed out of the actual blood plasma into this colander, and then we remove the potassium through this actual filter and put it back into the bloodstream, effectively removing potassium. So that's going to be the kind of the last line treatment. But here's what I want you to leave you guys with. Remember, there's a cause for the hyperkalemia. And if there is a cause for the hyperkalemia, what do you need to do? You have to treat the underlying cause. You have to figure out what is the underlying cause. If it's a kidney injury, then you have to be able to, unfortunately, maybe only dialysis is the best option for these patients, and trying other therapies that may help in preventing the continuous progression of kidney injury, right? But if it's all the other things that we talked about, those require particular medical therapies, discontinuing of a lot of medications that may be the thing to fix the person's hyperkalemia. So go back in those causes and start thinking about things that you can actually fix, and that's what you would do to actually treat hyperkalemia. And that covers the final discussion on hyperkalemia. All right, Ninja Nerds, in this video we talk about hyperkalemia. I hope it made sense. I hope that you guys enjoyed it. As always, Ninja Nerds, until next time.